Today, I think it's my turn to talk about the case, Ameloblastoma. The name itself is scary. As you know, the blastoma is a scary name. Never heard about it. I heard about many other blastomas, but never heard about ameloblastoma myself. So that is where we're going to start. Very rare at the age of 75. Now I'm 77, but it is rare at 75. And it is more common in 20s, 30s, and early 40s. That's what it happens. So there are all these rare things are there. And patient is nobody else but myself. I'm the patient actually. I'm 6 months post-op right now. I'm doing great. You didn't figure out because 2 months post-op I was in this meeting here. And you even didn't know that I had a complex, complicated surgery for ameloblastoma. And that's what I had. And I feel great, no pain. But the main thing happened really is now I'm to chew on one side. I cannot chew on the left side because that's where they took out my 3 teeth, took out whatever needs to be done. So I have to chew everything on right side. And I hope that my temporomandibular joint is strong enough to stand that chewing on just one side. But apart from that, I feel great. So let's talk about how all this started. If I'm wrong, you tell me now, Doc. Okay. Dr. Newberry is my dentist. Go to him. Well, before him, I went to Dr. Marshall every 6 months for a checkup. And I think it's about 3 years ago that he noticed just little swelling on left side, right outside the molar tooth or wisdom tooth on left side, left upper jaw. And at that time, as I said, I still have all my molar teeth, wisdom teeth, everything never taken out. And the last one on that side, the left upper, was little impacted. So we felt that maybe there was swelling around that. And that little swelling I have on left side. About a year and a half ago, I think, we felt it again, and it felt like a bone actually. Felt like exostosis on that side. But I think the real alarm was sounded last year, just about April or May, because that swelling, which was more like a soft tissue swelling, no symptoms, became bigger. And I think that is when Dr. Newberry felt that we need to do further workup and probably I need to have a biopsy. How the X-ray look. Here, you want to comment on your X-ray? You can say comment on your X-ray.
Well, when I was looking at it, it's got a radiolucency on the back side of the distal at number 16. You can see it at the apex. And it's got a very large filling, so I have been trying to get my patient to maybe get motivated and get his tooth on out for a little bit.
Yeah.
So anyway, so you've got that. I think that's what's going on. But the lesion, it's anterior to that. It's actually more on number 15. It's on the outside there. Oh dear. So the lesion is actually more right here in this area, clinically. But radiographically, I'm looking at this right here as a result of that filling. And like I said, you've got a doctor as a patient. You've got a doctor that's much more educated and much more knowledgeable than you as a patient. So you when he says, "Nah, we won't worry about it," we won't worry about stuff. So, anyways, that was what was going on for just a little bit of time, and he'd been asymptomatic with it. So
Yeah.
This is not a really good picture, but this is going to be the wisdom tooth right here, and this lesion is anterior to it. So it's starting to cover the molar, which that is never a good sign. I would, that's definitely something you want to get somebody to go see, in our case, in my case, an oral surgeon to follow up and get a biopsy on it. So at this point, I think I got this new camera, and I did not take a really good picture. I apologize already for that. And I believe that was this when you sort of were able to get a little bit more motivated for me when I showed you the picture?
Yeah, right.
Instead of you taking the fingers and pushing back there, and it's not that bad. So at this point, I think is where Dr. Mody was willing to go ahead and follow up and see. He could see my concern, and he could see the result of it there. And then I'll give it back to you there.
Yeah, thanks.
I'm gonna
So that is when the alarm sounded last summer, and every year I make a trip to India, and my nephew in India is a super specialist about all this situation. He also runs a clinic about implants and all that. So on my trip to India, I said, you check it out, and he did the special tests, the ultrasound, and the CAT scan, not just focused on that part, but focused on the whole face. And when he saw those pictures, he was just completely scared about the situation. So he still didn't wanted to tell me exactly what is going on, but he said, as soon as you get back to United States, you need to get biopsy done right away. So that is where everything started. So I went to Dr. Allen in Bowling Green. He made an appointment to see him. He took my wisdom tooth out along with whatever gross tumor he can take it out or gross swelling he can take it out. He was also not 100% convinced at this moment that itself is that serious. But still we took it out, did the biopsy, and then biopsy came out as an ameloblastoma. Now that is when we started talking. Ameloblastoma, as I said earlier, is a rare tumor. And some of them think that it actually begins from the cells when our teeth are developing. That's when it begins. In some, those cells stay dormant, they die out, and in some, those cells ultimately can change into ameloblastoma. And that's why it happens more also in younger age group than 77 years old men. I mean, that's how it is. So that is where we came, ameloblastoma. So I'm going to let Dr. Bruner, she is not involved whatsoever in this case because it was all done in Bowling Green. And from Bowling Green, the slides went to Louisville to special pathologist because they said they has to go to the special pathologist. So they went to Louisville. But still I asked Dr. Bruner to tell us something from pathology point of view about ameloblastoma.
Well, thank you, Dr. Mody, for inviting me to speak. We haven't really coordinated our presentations, so there's going to be some overlap. I'll just say a few things. This used to be called adamantinoma. Some of you may have heard it. You know, when I went in training, they used both names, adamantinoma or ameloblastoma. The early English word, amel stands for enamel, and the Greek word blasto means germ, so that's where they got ameloblastoma. As you said, this is considered a benign tumor. It's considered benign. They call it malignant if it metastasizes. So it's really benign, but it can be very aggressive. It's odontogenic epithelial origin, as he said. Although it's rare, it's the most common clinically significant odontogenic tumor. It's about 1% of all oral tumors and about 11% of the odontogenic tumors. And as you've said, it's diagnosed late because of poor symptoms and low prevalence. You don't see it that often. As you said, the peak incidence is the 3rd to 4th decades of life. So you're old to get this. Yes. The male to female ratio is 1:1, and as you said, in the Indian population, it's about 60% of all odontogenic tumors. So much higher in Indian people. The presentation, as you said, it can be the upper or the lower jaw, but more commonly in the mandible, 80%. And as you said, the 3 things to remember: it grows very, very slowly, but it's quite extremely aggressive. And there's a very high recurrence rate. As you said, a very slow-growing, painless swelling, and it can cause facial deformity. You can lose your teeth, malocclusion. It's often associated with teeth that are unerupted. It can displace the teeth adjacent to the mass, and it can cause resorption of roots. And it can be very aggressive. It can grow up into your nose, your sinuses, your eye sockets, and your skull. So here, as you can see, he has a somewhat subtle presentation, and that just right here, his jaw is slightly enlarged. That was how he presented. But this one, is much more obvious. Quite enlarged jaw. Just right here, some swellings. And this one's a little bit larger here with distortion of the teeth. And on radiology, because the tumor grows really slowly, it makes these loculations, and they look like honeycombs or soap bubbles. I'll show you some pictures. And because the bone grows slowly, it has these loculations. When you press on it, it wants to crack. So it's called crepitus. It sounds like breaking eggshells. So if you push on it, you can sometimes feel or hear that cracking noise. So here's what it often looks like. This little kind of honeycombing or soap bubbles. Imagine when you wash your hands and the soap bubbles up and forms all those little bubbles. That's what it kind of looks like. Again, these are bigger, but these loculations right here. And compared side to side, this side has the loculations. So for the pathology. Pathologists, people call us splitters. We like to split things out. We like to give things names. We don't lump things together. We split them out. So somebody has split ameloblastoma into 3 different categories. Okay, so there's the very conventional type, which is the most common, 86%. That's what we'll talk about the most. Then there's the unicystic type, which is 13%, and the extra osseous or peripheral type, which is 1%. Then there's also the metastasizing or malignant ameloblastoma. It's not really malignant. What makes it's the exact same tumor as the ones above. It is just spread. Once it has spread, then it becomes metastasizing, but it still histologically looks exactly the same. It's just spread. So the conventional type, just like we've been saying, classic clinical and radiographic presentation, presents slowly with the lump or the enlarged jaw, the lump in your mouth, the radiographic, the soap bubbles, usually in the mandible, can also be in the upper jaw. And as I said, we're splitters, so we can't just call it conventional ameloblastoma. We have to come up with 6 different patterns. So there are 6 different patterns. It does not matter. You don't have to know the patterns. You just have to know they all have a similar prognosis. So if somebody says, oh, well, this person's plexiform and this person's follicular, who cares? They're all the same. They're all going to have the same prognosis. But they all, in your pathology report, you may see one of these types. The only one that's a little bit different is the desmoplastic, because it looks a little bit different on the radiograms, and it tends to occur in the upper jaw instead of the lower jaw. But this is what it looks like under the microscope. Sorry, the pictures are in black and white, but you can see here the ameloblasts are lining, it's like an island. These are like islands of tissue. And the ameloblasts are lining up on the outside, and then you have this reticulum tissue in the center. And on lower power, see all these little islands? And you can just imagine they're like little fingers. Okay, and so this tumor is like little fingers trying to grow everywhere. It can grow into your sinuses, up into your eye sockets. It can grow everywhere. That's why it recurs so much, because the little islands can just grow everywhere. The next type, the one that's less common, is usually younger patients, much younger patients. And radiographically, it looks different. It looks like a large unicystic lesion. You don't see the soap bubbles. And so dentists often think this is a dentigerous cyst. So when you take it out thinking it's just a cyst, and then it comes back as ameloblastoma. Again, we like to split. So there's 3 types within this type. The first 2, luminal and interluminal, they are considered less aggressive than the conventional ameloblastoma, whereas the mural type has the same level of aggressiveness. So as a dentist, if you took out a luminal or intraluminal type thinking it was a dentigerous cyst, that's probably all you have to do, because they're not quite as aggressive. But if your histology comes back as the mural type, then you're going to have to do some more. And as you can see here, they do look different. Instead of the soap bubble appearance, they have this single cyst. And here's the lining, but then it's cystic. It's not solid like the other. The third type, the extraosseous peripheral type, very uncommon, 1%. The thing is, it's not in the bone. It's outside the bone. It's in the gums. It's in the gingiva. It's usually pedunculated. It can look like a fibroma. It's often mistaken for a fibroma. But you do have to rule out that this is not the conventional type that's just extending up into a pedunculated portion of the gingiva. Looks the same as conventional type. And this is the type, because it's just in the gingiva and it's pedunculated, usually you can just locally excise that and watch. And if it comes back, just keep excising, doing the little excisions. And then, as we said, the metastasizing. That's basically any of the above tumors that has spread. And you can only make the diagnosis after it has spread. Usually it goes to the lungs, and usually it occurs 10 years after the first treatment.
My pathology report, I mean, I don't have detailed report here, but it was a benign ameloblastoma. I think we talked about benign ameloblastoma, that it is a slow growing tumor. In fact, both my super specialists, one at Vanderbilt and one at UK Lexington, they both felt that the tumor what I had probably growing in for 15, 20 years. And I have no clue, because is it growing in a cavity, in a sinus. It started probably, according to them, somewhere between my two molar teeth, and instead of growing out, it decided to grow in maxillary sinus. And it was growing for 15, 20 years, no symptoms whatsoever, until we noticed this little swelling on a gum outside. That is the first sign or symptoms, whatever you call, was that about 3 years ago. So both of them felt that this is ongoing for a long time. So as you can tell, I went to two places. Vanderbilt was the first one. Saw maxillofacial surgeon. She also ordered CAT scan again. But then the plan there was a more radical approach. Like we talked about, that they all like to get clear margin around the tumor. But I don't know how they can get a clear 1 or 2 cm margin to prevent recurrence. There was no way. The way it was in maxillary sinus, I'm going to show you the picture. Very scary picture, actually. Myself, the family almost fell apart. Surgeon was scared too. That's how the pictures are. I'm going to show you. So that was the one opinion down in Vanderbilt. The opinion was to do a radical surgery, just like they do it for any cancer. The only difference is this is a benign, slow-growing tumor which has a tendency of local recurrence. So that was the approach. 8-10 hours of operation, includes a plastic surgeon in the team, reconstruction of the maxilla, go through rehab for long period of time, because it was going to affect speech, because they will be operating on maxilla, and was also going to affect swallowing. So there was a long term rehab. And then if everything goes smooth down the road, long implants. So that was one approach at Vanderbilt. Well, we came home and we just completely fell apart. I said, I'm done. That is it. Can't stand all what I have to go through, what they were talking. So that was the time we decided that I need to take a second opinion. You know, as a surgeon, sometimes even myself, I don't like if somebody goes and takes a second opinion. But still, I encourage even my patient to take a second opinion when I'm not sure myself. If somebody wants to take a second opinion about when I was doing surgery, hernia or taking a gallbladder out or doing a biopsy, then many times I wonder why they want to take a second opinion. But if somebody has a tumor in the pancreas, tumor in the liver, tumor in the stomach, which I don't deal with many times, then many times I encourage them to take a second opinion. And that is how it was. But the Vanderbilt group was set to ready to go. And I said, I need to take a second opinion. My daughter lives in Lexington, and she knows people at the University of Kentucky. So made appointment in 3 days. Otherwise, you cannot get to see this super specialist for 6 weeks, 2 months actually. But I got to see them in 3 days. And this is where he said, we'll talk about this. So I'm going to show you the MRI he did before the surgery. So that's what it is coming up. There, okay. You see the two sides, maxillary sinus. One side is clear, other side you see the opaque thing. But the most scary thing you will see, there it is. Okay, what you see there, filling up the whole maxillary sinus. Now it gives you even a better picture. Now why you can tell why everybody was scared, including me, and both super specialists were scared. How to deal with this tumor in maxillary sinus, because you can see right now, pressing on my lateral wall of the nose. Coming here is ethmoidal sinus and frontal sinuses. Coming right under the orbital floor, and that's how big it was. And they were scared. And on top of that, he said, I was more scared because you're surgeon. So that is where we started. But then he was little happier seeing this MRI, this view, because you see the main tumor right here, and then around there you see little less darkness. And he thought that what you see going toward the ethmoidal sinus and going under the orbit is probably maybe some thickened mucus or fluid. Over this many years, there has to be some mucus and some fluid, and it was good that it was surrounding the tumor. So that is how the MRI looked. And that is when we talked. We sat down, we talked, and this was his reasoning about the way he approached this case. He said, this is scary tumor, rare tumor, but still it is a benign. It also has a chance of local recurrence. That I know. He said, I know that it has a chance of local recurrence. But he said, you are 77 years old, and even if it recurs again, there are always ways we can take care of that. 77 years old, to put him through 8-10 hours of operation, going through all the rehab for speech and swallowing, and still taking all the risk of post-op complications, he thought this was a better approach. And that was the reasoning of conservative approach. And if he said, if it comes back, he said, I cannot give you guarantee, but I can almost tell you that if everything goes where I think it will go, you won't even know for 10, 15 more years. It will be there slow growing. And even if it comes back, we can always do something more. We can scrape it out. And I was talking to Dr. Allen. He has a case in Bowling Green, 20-some years. Patient doesn't want to go through radical surgery, and they just go in and try to scoop it out, scrape it out, and keep going. So that was his logic about going conservative surgery on me. And this is what he told me also. Real nice doctor. Sat down, talked, showed me MRI. And he was still worried though that how is he going to free it up from maxillary sinus? So then he said, if it was my dad, I will do the same thing if he was 77 years old. Then I said, let's just go and get it done. There's no point in thinking about it, waiting about it, trying to go. Somebody said, you go to Sloan Kettering Memorial in New York, and some says you go to Mayo Clinic. I said, no, I'm happy with what he says, and that decision we made, that we're going to stay with him and get it done. So exactly 6 months ago, I had a surgery done. And as I said, you cannot tell right now, even 2 months post-op, you cannot, that I had a major complicated surgery, because it was all inside. It's done from inside. Not only it is done inside, they took my 3 teeth out, 2 molars and 1 premolar, along with the gums and along with the margin of the maxilla. And then they went in a sinus. And this is what they got it out from the sinus. There. 6 centimeter by 5 centimeter tumor in maxillary sinus. You see my teeth hanging out here. They think this is the whole tumor. It almost felt like it was connected here, growing between 2 teeth, going in the maxillary sinus, and some outside on the gum. But this is what it was, 5 centimeter by a 6 centimeter tumor. The good thing, his plan was that it may take about 5-6 hours to free it up, get it out, and get it done. Well, he got it done in 2 hours. And my wife said when he came out in 2 hours instead of 5 hours, she got scared that maybe they had to quit halfway. But what happened is, when they took my teeth out, took the gum out, took the margin of the maxilla out, and went in the sinus, the tumor just came out as if it's encapsulated tumor. He said he just had to pull and wiggle, and it just came right out. And he said that was also because there was some fluid around it, what we saw on MRI. So that is how it came out. The outcome was good. We all happy. Hour and a half of operation instead of 5 hours. No rehab. He has to raise a flap. You know, once you take the teeth out, gum out, lower part of the maxilla out, he has to raise a local flap from inside the cheek to cover all that. So I have a flap, I can feel that. But it doesn't bother me, there's a flap covering all that area. The worst part of that was they packed the maxillary sinus, and the packing came out through my nose, through the lateral wall actually. See there, took the tumor out here and went in nose, and packing came out. So 6 days later, I had to go back to office, and you can imagine somebody pulling that big packing out through your nose, through the maxillary, coming out through the maxillary sinus. But that is what he did. He took out that 6 days later. I went back after that a month later, and he did the x-rays, everything looks clean. So he turned me loose for a year. He's so happy with the surgery. He was so happy with everything what looks inside the mouth, the flap, the healing, that I don't need to see you for a year. The follow-up is going to be same thing. Do another MRI when I go back and see how everything else looks. But it is once a year checkup. So I made a condition with him, because we all doctors nowadays have a tendency to move too quick. You know, we move. Every few years we move. So I told him, I said, when I come back, and if you've gone from here in UK, I'm to come wherever you are. And he was real laughing about that I'm going to follow him. I said, you follow me, and I'm going to follow you. So that's where we are today. Still main concern at this moment is still local recurrence. But then his explanation, as I said, was that if I run into something unexpected, if I have 10 good years like I have right now, then we're in good shape. So then I compare myself now to what they were suggesting at Vanderbilt. I just cannot imagine those times. So that is where all those things came at ameloblastoma. That is all they told me. I talked to the fellow down there who is from Egypt, and that is when he told me all the statistics, that we don't see ameloblastoma around here as much. It is more common for whatever reason, whether chewing tobacco has something to do with that, or Middle East, Asia, they have a tendency to eat those leaves and betel nuts, and all that has to do with it. They don't know why it is more common in India and Egypt. So that is the situation here. Many of the even doctors haven't heard it. Many of the doctors haven't seen a case. Some of the dentists also haven't seen a case of ameloblastoma. That's that rare. So I thought it'd be a good case for all of us to know about it. And now you all can see how good everything is going for me. And I'm pushing everything as hard. I have put everything on what you call fast speed, because he has given me at least time frame. That 10 years is your time frame. I at least can tell you that there is no issue unless something unexpected. So I am trying to get everything on higher speed, what I want to do in 10 years. Then I don't know what's going to happen. So that's how it is. I think that's all I know about this tumor, and I was told by both specialists from both hands about ameloblastoma. Unless anybody has any questions, if anybody knows about it, this is the time to talk about it.